something right now you're doing where you're starting to see change? Now, we talked about the Tommy John already. Like, oh, this surgery I've been doing for so long like this. There's now newer research. We're now doing it a bit differently.
Yeah, so that, like, for example, you'll see now, you guys are probably seeing it here with some players you treat, that there's some evolution on ACL reconstruction. You're seeing more quad tendon reconstructions. Maybe you haven't seen it. Or
Yeah, we've seen some. That's always because I always refer to, like, work with, like, the Suarez team at Allison, or like Sam Arnold at Nicola, where you have parents ask, like, what's the best graft? And I'm like, I honestly don't know. We've seen success from all of them, and we've seen setbacks from all of them.
100%. So there's a lot of factors that go into it, and so, like, in anything, we try to go back by science that this is, and concepts, So, for example, the quad, you think it's a good tissue. You can get a pretty big graft out of the thing, but time will tell. So so far I think there's still good options for the ACL, but there's always evolution, and now we're adding some biology to it. For example, some of these soft tissue grafts, I'll use the internal brace like we talked before. Meaning that maybe we're taking a little stress off the repair. There's also been some changes on. There was an old procedure they used to do, before even my time. For ACL, they didn't have the arthroscopic surgery, so they weren't doing the reconstructions like all you guys have seen this. So this is before my time. So they would do some what we call extra-articular reconstructions, where they would take some tissue and do this and that and give you some stability. So now there's some evolution of this, what we call, you'll see maybe people, if you're getting your op reports, it says LET, lateral extra-articular.
We're seeing that with ACLs, and we've seen great outcomes with that with ACLs.
So the LET is doing an old school procedure and adding it to the ACL. So, for example, if someone has a revision, someone's had ACL, whatever graft, they've retorn it, then the thought is by adding that other portion of the procedure, which I can explain in a second, will give you some rotational stability and take some stress off the graft. Or if I see somebody, I'm looking at their other knee. So you hurt your knee, you're going to be a little stiff. You go to therapy to get optimized before surgery. But if we see your other knee that is not injured, has significant what we call hyperextension, goes straighter than straight, those are ones that I may be thinking about adding the LET. So you do your reconstruction. LET means you're taking a strip of tissue that's on the outside of the leg, your ITB, attaches down near to your knee on the outside. So we leave it attached near the knee, take a strip that's about 8 centimeters long, 1 centimeter wide. So now we got this strip that we put some stitches in, kind of weave it around in a certain position, and then reattach it to give us some rotational stability on the thing. So another incision on there, but we do find it, I think, in the revision setting. And if you don't want to do everything all the time if it's not necessary, but if there's certain things that we think are going to enhance our, outcomes and take some stress off the ligament, then, I think it's something that's good. And that's why we always want to have studies. And like you said, we're doing things differently today in some ways than we did, 2 years ago, 5 years ago, 10 years ago.